What I'm going to talk about today is basically the complications that I've had or I've seen, and hope that you can learn from them. Some of them are common sense. Some of them you've probably never seen before and hopefully never do because you learn from this talk. And then there's, I think, a few kind of life lessons that translate from the OR to life. So I put together the Cohen top 10. I don't know how many in the room actually know who David Letterman is anymore. It's a pretty young room, but he had a nice top 10. I won't make you do a drum roll or anything at the end, so bear with me here. All right, so patient selection. So bigger isn't always better when it comes to direct anterior approach when you're doing your first 50 cases. I think you should choose your cases appropriately, and already talked about the wide iliac wings, the short varus necks, the stiff hips. That's your working distance. And so those are the ones you're going to want to watch out for early on. The hip flexion contractures and the hip fusions are going to make femoral exposure difficult, as Matt Darren told us earlier. Number 2, pre-op preparation. Success is not about luck. It's about preparation meeting opportunity. And I believe that in the OR and in life. And so really it starts from the very beginning. It starts with setting the patient and family expectations about what the surgery is, what you expect for the recovery, and how you expect them to recover. It starts with preoperative templating, like we saw earlier, knowing the sizes of your implants, discussing with your rep, having them bring everything that you think you might need. And that's not just bringing one of everything, that's bringing 2 of everything, because one of the complications is that one 54 cup that you needed hitting the floor, and now you're in the ASC, and the next cup's an hour away. So planning ahead is going to be key. I know it's obvious, probably doesn't need to be said in this room, but I've experienced that. And then team member briefing. If I know I have a hard case, I'm involving everyone in the room before I start that case. I tell them, hey, this is going to be a difficult case. This is why. This patient's, BMI is 45. They have this. It's a fused hip. I might need an augment. This is plan A, B, and C, and this is what I might need. Just by doing that, one, engages the entire room. It also makes them kind of work for you. They'll run, help you, and every time I do that, I find the case goes easy. It's actually the hardest case of my day ends up being the easiest case of my day. It's usually the easy case that maybe you overlook. So maybe do this for everybody. Number 3, room and table setup. So we had a lot of information today about the room and table. You'll really want to make sure you're set up for success, and no one's going to care more about this than you. I think the vast majority in the room are using hand table, and there's a lot of dangers with the hand table if you're not careful. Make sure the bed is locked. That's the obvious. Make sure you have a safety belt that's above the spar, not under the spar. You want to make sure that the boot is actually locked in to the spar, and that nut is tight. So if you have the nurse or your assistant rotate the leg to 120 degrees and that boot's not locked, it's coming out, it's hitting the floor. And I see that happen a lot with junior surgeons. So it's something that's really overlooked. It's very hectic. You're getting set up for the big case. You're excited. Check and make sure the patient's actually locked in on the bed. And then finally, do not remove, the hand table is a very narrow bed, like it was said earlier. Don't remove that post until you're ready to move the patient. It actually happened at one of our hospitals. Someone removed the post, turned around to do something else, turned back, patient wasn't there on the floor, okay? Number 4, draping and incision placement. So I don't care how you drape. You need to drape everything in and plan for the complication. You need access to the iliac wing. You need access to the entire femur. And although I do like a big hitting incision, I'll say if you have a difficult case and you're starting out, vertical incision is an extensile. You can extend that into a lazy S incision. We're going to hear about that here in a minute, how to do an extension. But no reason to be cute and do the bikini incision in your first 50, 100 cases, or maybe a complex case. You really should be doing a vertical incision. There's a lot to be debated about that. There's going to be a great debate later, but that's my 2 cents on that. Number 5, the correct interval. So this is for life and in the OR. The 2 most important requirements for major success are, first, being in the right place at the right time, and second, doing something about it. And so what I mean by that is you can get very excited to get down and do the case, but you want to make sure you're in the right spot. The elderly, thin female that's sarcopenic with a small tensor, it's an easy case, right? Well, what's not easy about it is their tensor is actually about this big, and it's very easy to overlook the tensor and actually get caught medial. So a couple of things I'm always checking on these cases is I'm making sure I'm lateral to the ASAS. If you're medial, you're lost. So remember, if you're lost if you're medial. So palpate the ASAS, make sure you're lateral. And then you can see here, there's a little fascia over top of the sartorius. So the tensor and the sartorius look very different. The tensor is just straight muscle fibers, and the sartorius actually has a fascia and it does aim a little medial, but can be difficult to tell in a very thin sarcopenic patient. But that fascia, if you're medial to that fascia over top, you're heading in the wrong direction, you're heading into trouble. So those are my two big checks when I'm trying to make sure I'm in the correct interval to start. Number 6, careful anterior retractor placement. You do not want to get on the femoral nerve. So if you are placing an anterior retractor, always use two hands. I'm going perpendicular to the ilioinguinal ligament and making sure I'm staying on bone. So that's going to be on a right hip in the 30 to 60 degree mark. If you're heading directly medial or 90 degrees, the femoral nerve is 16.6 millimeters away. And while femoral nerve palsies are rare, they're not impossible. I've had them in my own practice, and they actually present kind of subtle. It's not like a foot drop that you see in a posterior approach from a sciatic nerve injury. You know, foot drop's pretty obvious to everyone. These patients will present with some medial thigh numbness and some even buckling of their knee, or their knee will give way. They may actually fall with a femoral nerve palsy. And it may present a day or two later and like slowly progressive from swelling. Say you got the retractor too medial and got a bleeder that's right next to the femoral nerve. So be aware of that. So the number one causes are aberrant retractor placement, excessive traction. So again, the small female with the degenerative spine. You know, if you have your assistant, again, communication, if you say, okay, pull traction, and they're pulling as hard as they can, you know, they're going to pull that whole leg off. Well, what's going to happen is you're going to have basically a double crush phenomenon. So they have already some lumbar spine disease, and now you're pulling traction on the nerve, and they'll present with the femoral nerve palsy, and then being in the wrong interval. The treatment is rule out other causes, so I'm always thinking, can this be a disc? Is this an acute disc? That's treatable, right? The vast majority aren't caused by anything else but your error. And so it's, you know, patient counseling, discussion. Most of these resolve in about a year, unlike sciatic nerve palsies. So you're just going to have to be patient and counsel them. I treat this with a knee immobilizer if their knee is buckling, and then steroids, IV Decadron, 10 milligrams Q6 while they're in the hospital, then send them out on a Medrol dose pack to minimize femoral nerve swelling and also to treat concomitant spine disease. If you get way medial or lost, this is probably like the worst complication you can think of in the anterior approach is the femoral artery, like a femoral artery injury. If it happens, it's an emergency. You need to notify the anesthesiologist up top. They need to get blood in the room. You need a vascular surgeon to come. If you're an ASC or a vascular surgeon's not available, I mean, you literally have minutes. So I think anyone who's doing anterior approach, and this may sound extreme, you should at least know how to do a femoral artery cut down. We're all orthopedic surgeons. You should know how to get control of vessels until someone can come help, because this would be a patient's life on the line if you got into a femoral artery. So how do you do a femoral artery cut down? So you're going to palpate the pubic tubercle and the SAS. You're going to go midline in between. And about 8-inch incision. Remember, it's a trauma situation, so bigger is better. We're not going for small incisions here. You're going to head towards the medial knee, and you're going to be proximal. You want to be proximal to the groin crease. The femoral artery goes under the inguinal ligament, and the inguinal ligament is proximal to the groin crease. So you're going to make that incision through skin and subcutaneous tissue. You can use 2 big rakes and spread pretty aggressively here until you see a fascia. The fascia is going to be white, it's tensor fascia. You make an incision in the tensor fascia, and then the neurovascular bundle is going to be right there. The profunda artery comes off, you can see here, comes off posterior and medial, and so you use a vessel loop and gain proximal control of the femoral artery until you can get your vascular surgeon there. So luckily, I've never experienced this. I don't want to ever experience this, but I have spoken to surgeons that have experienced this, and it's a dreadful complication. Number 7, protect the anterior wall. The anterior wall is your friend. It's kind of been discussed a lot. It is your friend. You need the anterior wall, okay? It not only protects from impingement from the iliopsoas, but it also gives you fixation, right? And so I'm feeling the anterior wall before I start. There's some patients that actually have kind of a small, shallow anterior wall, so those are ones you're going to want to be extra careful with. The sclerotic posterior bone, especially if you're using a single reamer, can push you up anteriorly, and all it takes is just 1 second. And Charlie was talking about hearing. You'll hear a crack. You'll hear cortical bone being missing, and then it's over. There's no more anterior wall after that. So I'll ream into the posterior bone a little bit to make sure it doesn't push me up anterior. A long neck cut can push you up anteriorly and make acetabular access difficult. So if I'm having issues, I'll actually revise my neck cut for those. And then a large tensor and a big muscular male obviously is going to push you up anterior as well. I always ream anterior to posterior, so my hand, the reamer, straight reamer is going like this. So I can tuck the reamer under the anterior wall, so I'm not accidentally going to grab some of the anterior wall. You don't want to oversize the cup. If it's a dysplastic hip, and you measure the femoral head on the back table, the cup size is going to be about the size of the femoral head, or maybe even a touch smaller on a dysplastic hip. And for a standard hip, it's usually within 4 millimeters. So if you're getting way above your templates, that kind of means there's a problem. So how do you recover? If you have room to medialize, you can continue to medialize. That will effectively create more anterior wall. But if you don't have a lot of room for medialization, then you're really relying on a pinch between your anterior and posterior columns, and it turns into a revision situation. You need a slightly larger cup. I go multi-hole cup, and then I put my inferior screws in first. So when I put the superior screws, the whole cup doesn't just go vertical. So you always need inferior screws to anchor it down and to gain that rotational stability, like you can see in this X-ray here. Exposure. Everyone's talked about exposure today. It's certainly the most important, and I would argue the femoral neck cut is probably the most important part of the entire case. It's really going to dictate the tone of the case, the cadence of the case. It's going to allow easy acetabular exposure. It's going to allow easy femoral exposure. And what I mean by that is I use the innominate tubercle as my landmark, and very similar to Eric, who presented earlier, I want my neck cut to go directly in front of or proximal to the innominate tubercle into that lateral cortical bone. That allows me to get lateral with my broaching. It also makes it very easy for my bovie to go straight across and do my femoral release. If you have a big lateral shoulder, it's going to be hard to place that retractor. It's going to be hard to use that bovie. And then you want to always make sure you complete your neck cut medially. Most importantly, you can't just crack it open if you didn't complete it medially. That's when you're going to get calcar fracture. And if you cut too deep posterior laterally, that's going to be a greater trochanter tip fracture, which I'll show earlier. Doesn't affect patient recovery, but it's kind of style points. Another advantage, another femoral exposure, if all the resets and releases that Matt Darren told you didn't work, you can then do a quad snip, similar to a quad snip and a total knee, in that it gives you better exposure, doesn't change your protocol, and doesn't affect the patient. Now, if you have a fracture, it all depends on what the fracture is. You have been given the tools to fix it. The greater trochanter fracture, actually don't worry about. Okay, the beauty of the anterior approach is you don't violate the abductors, you don't violate the vastus lateralis, and so that complete soft tissue is intact. So this is a complex revision that I did. There's a greater trochanter fracture, and at a year, it healed in follow-up with no fixation. This is just a picture of a greater trochanter tip fracture that you just have to see every year and follow up when they come back. And it's just a reminder that you kind of messed up on your neck cut there. Calcar fractures treated just like it would be any other approach with removal of the stem, cable, and a final stem. And then diaphyseal fracture, you're going to use that extended lazy S incision we're going to hear about. You need a cable and bypass it with a diaphyseal stem. Number 9, the femoral head. Don't lose your head. So don't lose your head in the OR, and don't lose the femoral head in the OR. Those are two never-ever events for you in the anterior approach. So if I have a hard case, like a tight rectus, a hip flexion contracture, or we're trying to gain a lot of length, the patient's really short, I'll go ahead and tag the femoral head so I know I can easily retrieve it. Or if I'm letting the fellows reduce the hip, I'll usually tag it so I know they won't lose it. And then I always keep my finger on the femoral head as we're reducing it to keep control of that. Same with the dislocation as well. Because if you don't keep track of it, then it's going to be lost in space, and that's kind of an oh shit moment. So what happens is the ball will go up under the rectus into the iliopsoas and go into the inner pelvic brim. up into that iliopsoas bursa, and you're going to need to retrieve it. And that's why you need to really drape out the iliac wing, not just for proximal exposure, but so you can do a lateral window. You're going to make an incision over the iliac wing through the fascia. You can actually dissect the iliacus off and gain access to the inner pelvis. Now, if it gets pushed retroperitoneal, that's a whole different story, and you got to call general surgery. That's an open abdomen case. Again, another bad day in the OR. And then number 10, scrutinize intraoperative images. If you're taking fluoro, you need to look at it. A picture's worth 1,000 words, and I think really what it comes down to is tunnel vision. And you get so focused on one thing, like I'm going to look at the femur, I'm going to look at how good my cup is, that you actually miss everything else that's going on. So really scrutinize your intraoperative images. I think experienced surgeons are doing this kind of naturally, but as you start, if you haven't seen a complication, then you don't know what to look for. And so what I'm looking for on my images, I'm getting AP and lateral images. I'm checking the fit, fill, and alignment of my stem. I'm making sure there's no perforation of the femur by getting the two laterals, looking at cup position, and making sure there's no fracture of the acetabulum or the femur. And then I'm making sure the cup and ball is concentric. You can have bone pieces that can affect making it eccentric, or maybe the wrong head size was opened and you put a 36 instead of a 32. These things have happened, and you can catch this before you leave the OR and fix it. And if you don't, then you're going to have a bad day in the OR. So this was just an AP was obtained. You can see that something's going on the PACU X-ray, that the stem's kind of over the lateral medial cortex. Let's get another view. Boom, out the back, posterior cortex, perforation, bad day, need to go back. And how you deal with cortical perforations is you can graft them and then just bypass them with a stem. And then the final bad day in the OR, hope you guys remember all of this so you don't make any of these mistakes, is this was acetabular revision, loose cup. You can see on that fluoro image, it looks like you're kind of seeing a lot of the trunnion for a +5 head. Well, a patient got up the next day. I think it was the ball was pulled off with a reduction from probably a rectus or not enough exposure. Again, more exposure. And a patient stood up and, basically dislocated her hip, right? Like the ball's no longer on the trunnion. So she had to go back. There's a 32 +5 head. Looks better on the trunnion. Again, the ball looks concentric in the cup. It's not eccentric. There's no bone in there. And that's how the X-ray should look. That's kind of typical tunnel vision there. So I think I'm a little over time, but thank you all for listening, and I hope you can learn from my mistakes and not make the same mistakes again.